Okay, today we are going to discuss another topic or important topic of neonatology, that is the neonatal sepsis. Neonatal sepsis is basically a clinical syndrome that is systemic response to infection. It's one of the exaggerated inflammatory response that leads to widespread tissue injury. When we define it, it's a clinical syndrome of systemic illness that is accompanied by bacteremia occurring during the first month of life. This is a cascade of events, how the one step follows each other. Once there is any infection, entry of organism to the body, that leads to the SIRS, that is called the systemic inflammatory response syndrome. What is SIRS? It's clinical response arising from non-specific insults. And any one of these tools, like if the temperature is hypothermia or hyperthermia, or once there is tachycardia, that is heart rate in your rate is more than 160, and respiratory rate in newborns more than 60, and WBC count, that is we count as the absolute neutrophil count, that is more than 12,000, and if we count the ANC, it's from either neutropenia or neutrophilia. So any two of these, if they are positive, then we label the patient as SIRS. So SIRS has three vitals and one lab. That is, three vitals are the temperature, heart rate, and respiration, and the WBC count is one there. So just on the clinical basis, just on the examination of the vitals, you can assess about the systemic inflammatory response syndrome. Once this systemic inflammatory response syndrome with a presumed or confirmed infectious process, that is called the sepsis. So SIRS might be because of infection, might be because of other causes as well. So once there is SIRS secondary to infection, this is called the sepsis. And what is severe sepsis? Whenever there is SIRS with infection, with any sign, one or more than one sign of the organ dysfunction, that is called the severe sepsis, like hypoperfusion or hypotension, or if there is any involvement of the cardiovascular refractory hypotension, that will be called as the shock. So if there is an involvement of cardiovascular system, renal involvement, respiratory involvement, hepatic involvement, hematologic involvement, CNS, or any unexplained metabolic acidosis is there, that will be labeled as the severe sepsis. So the patient will start problem from the infection. Infection will lead to the SIRS. If SIRS is secondary to infection, that is called sepsis. And if there is sepsis along with one or more than one organ dysfunction, that will be labeled as the severe sepsis. And if severe sepsis leads to the refractory hypotension, means you are treating the patient with different types of IV fluid, but patient is not responding and patient needs vasopressor agents. So this is called the refractory hypotension. And if there is refractory hypotension, the patient has septic shock. So these are the different types of organ dysfunctions which may occur with the severe sepsis. What is septic shock? When there is severe sepsis plus one of the following, means when you are, whatever the fluids you are giving, but the patient is not maintaining his blood pressure, and patient needs vasopressor agent. So we will label patient as the septic shock. So this is sepsis syndrome. Initially there is infection. Infection might be because of parasite, virus, fungus, or bacteria. Any one of these may lead to the sepsis. And sepsis infection secondary to all these organisms will lead to the SIRS. But SIRS may also be because of the trauma, because of the burns, and ultimately there are many other causes as well. But if there is this involvement of all these, this will lead to the severe SIRS or severe sepsis. And once this SIRS is secondary to the infectious process, it is called the sepsis. And ultimately, sepsis with organ dysfunction is severe sepsis. And if this sepsis is secondary to the bacteria, this is called the bloodstream infection or BSI. So I told you it is severe sepsis leading to the refractory hypotension. This is called the septic shock. So as far as the incidence is concerned, it's 1 to 5 per 1,000 live births. But these are the international studies. In our setup, it's very high because of the poor hygiene, because of the more and more premature deliveries. It's very high, and even higher in the low birth rates, very low birth rate. With early onset sepsis rate that is 2% and late onset or nosocomial sepsis rate that may reach up to the 36% in the babies who are very low birth weight. And mortality also depends upon the clinical severity and when the patient arrives and he is going to be treated. If it takes too much time, once the patient develops refractory hypotension, then the mortality rate is very high. But if patient is coming soon with just the symptoms of SIRS, then the mortality is less. Etiology, as I told you, once the most common reason for the sepsis in newborn is secondary to the different types of rectal infection. That is called the bloodstream infection. This is because of the E. coli, Klebsiella, Pseudomonas, Group B, Streptococcus, Staph, Proteus, Listeria. These all lead to the bloodstream infection. Now, this sepsis is classified into 3 categories: early onset sepsis, late onset, and very late onset, or late onset. That is the 3rd category. So, early onset sepsis, this starts from 7th birth to 7th day of life. Means usually the symptoms start before 72 hours. And late onset sepsis, that starts from 7th day of life up to the 31st month. There is usually multisystemic fulminant illness with prominent respiratory symptoms. In the early onset sepsis, respiratory symptoms are the chief complaint, and in late onset sepsis, this is usually focal. The onset is insidious. Most often, the symptoms are related with the meningitis. This is acquired, early onset sepsis is acquired during the intrapartum period from the maternal genital tract. And the late onset sepsis is acquired either from the maternal genital tract or from the environment. The risk factors for the early onset sepsis are the prematurity, chorioamnitis, untreated maternal sepsis, or during delivery if there is organism colonizing the maternal genital tract, or if there is exposure to the organism after delivery. Here, once the patient is admitted because of the prematurity, very low birth weight, or any complaint related with the very low birth weight or prematurity, then ultimately they are at risk to develop the infection because of their poor hand hygiene, low birth weight, lack of initiation of the breastfeeding, superficial infections like pyoderma, umbilical sepsis, or dissolution of the skin integrity with the use of skin needle plates and IV fluids in the hospital. And 3rd category is very late or late onset, that is the nosocomial sepsis. This occurs in high risk newborn and after the 30th day of life. And the pathogenesis is related to the underlying illness of the infant, whatever the flora is there in an ICU, and the invasive monitoring. And the source of infection is either environment, community, or from the hospital. What happens in sepsis? There is uncontrolled, unregulated, self-sustaining intravascular inflammation. And there is simultaneous release of both pro-inflammatory and inflammatory elements that lead to the out of balance and extending otherwise to the normal tissue. There is significant consequences of systemic pro-inflammatory action that leads to the endothelial damage, microvascular dysfunction, impaired tissue oxygenation, and ultimately the end organ damage. Here you can see there is involvement of the bloodstream infection leading to the microvascular dysfunction with inflammatory response, coagulation, fibrinolysis. Ultimately, there is hypoperfusion and hypoxia, and this ultimately lead to the end organ damage. What are the host factors? Because the newborn is immunocompromised because of the impaired all the three immune responses, that is impaired cellular response, impaired humoral response, and the improper functioning complements level. And what are the factors which are related with the mother? Mother might be poor socioeconomic status. There is prolonged rupture of membranes, means rupture of membrane before 18 hours of delivery, and maternal peripartum infection. Or if there is chorioamnitis to the mother, that is major risk factor, and the criteria for diagnosis is the fever to the mother, maternal leukocytosis, maternal tachycardia, fetal tachycardia, uterine tenderness, the fall order of the amniotic fluid. Other factors are the prolonged labor, previous delivery of neonate with the group B streptococcus. It means the mother's genital tract is colonized with the group D streptococcus. Or if there is multiple gestation or maternal colonization of cervix with the infectious agents like E. coli, group B streptococcus, or any other organism. Environmental factor might be home delivery, very low birth weight, baby, prematurity, birth asphyxia, bacterial contamination at the time of delivery or labor, invasive procedures, maternal metabolic factors like hypoxia, acidosis, galactosemia, ischemia. These all will lead to the poor immune response. Other factors may be related with the sex, race, variations in immune function, improper hand washing, improper card care, bottle feeding. They all are the risk factors for the neonatal sepsis. Here you can see different types of infections leading to the problem in the newborn. Some infections are the congenital, some are related with the postnatal, other may be perinatal. So all these will lead to the sepsis. How the clinical response or clinical presentation is there? The initial diagnosis, as I told you, three important factors which tell you about the sepsis are the vitals, that is the heart rate, respiratory rate, and temperature. So initial diagnosis is clinical one. It's crucial to begin treatment before the results of culture. Once you send the blood culture, you have to start the treatment empirically. Until you will not treat, patient will develop the complications. So clinical signs and symptoms are sepsis or non-specific, and differential diagnosis is very broad. Focal infection might be like cellulitis, impetigo, abscess, tonsillitis, congenital tonsillitis, conjunctivitis, otitis, media, meningitis, osteomyelitis. So depending upon the whatever the site or focal infection is. In the clinical presentation, there may be hypothermia and preterm, hypothermia and full term, lethargy, irritability, changes in tone, poor perfusion, mottling, cyanosis, pallor, different types of rashes, feeding intolerances, diarrhea, abdominal distension. There might be tachypnea, grunting, flaring, as I told you in my previous lecture, all the signs of respiratory distress. So any organ system might be affected once you are getting the patient, once the patient is getting the this sepsis. Might be involvement of the temperature, color, skin changes, feeding problems, cardiovascular involvement, pulmonary involvement, metabolic involvement. All the organ system might be affected once the patient is developing the bloodstream infection or sepsis. How you diagnose? Basically, the SIRS has clinical diagnosis, but once you are thinking about the bloodstream infection or sepsis, you have to go for the cultures. Without culture, we cannot say that patient has confirmed sepsis. Until unless you the culture report, you will label the patient as presumed sepsis. And once you get the positive culture, then you will label the patient as the sepsis, confirmed sepsis. So you can send the blood culture, urine culture, CSF culture, depending upon the sign and symptom to the patient. Or if the patient is hospitalized, you can send the tracheal culture or gram stain of various fluids. Other helpful tests are the blood, complete blood count that may show neutrophilia or neutropenia, platelet count might be low, and there is the PSR might be acute phase reactant that might be high. Other acute phase reactants like CRP levels, cytokine levels, procalcitonin, and neutrophil surface antigen might be positive. These all are the acute phase reactants that might be generated secondary to the inflammatory response. Or if there is any involvement of the respiratory involvement, or depending upon the involvement of the organ system, you can do the X-ray, you can do the unit rate imaging, you can do the CT scan, you can do the CSFTR. So all these depends upon the symptoms to the patient, and the examination of glass and ventricle membrane for evidence of the chorioamnitis. As I told you, it's one of the major risk factors. Now, the treatment is divided into the two categories. One is the general treatment, other is the specific treatment. In general treatment, you have to do the good temperature control so that you should keep the patient in neutral thermal environment. I told you already about the neutral thermal environment, and so that there should be no risk of hypothermia or hyperthermia. And monitor the vitals 4 hourly. There should be strict input-out record, and there should be fluid and electrolyte balances by giving the proper amount of IV fluids so that patient should not be dehydrated or overhydrated. And steroids, if patient has septic shock, and if there is refractory hypotension, we can use the dopamine as well. In general treatment, you can give oxygen for the respiratory system. If patient has improper breathing, then you can use the ventilator support. Cardiovascular support you can give by the volume expanders, by the vasopressors. Hematologic support you can give by the treating DIC with the FFP, cryoprecipitate, and transfuse blood if there is anemic, slow hemoglobin. If there is convulsions, you have to treat the seizures with phenobarbital, and if there is any sign of syndrome of inappropriate ADH secretion, then you have to monitor for that. That is coming with the decreased urine output and hyponatremia. In metabolic, if there is any hypoglycemia, hypocalcemia, metabolic acidosis, you have to treat accordingly. And the specific treatment is by giving the broad spectrum antibiotics for 7 to 10 days. And in case of meningitis, you have to give for the 14 to 21 days of life. And finally, once you are getting the culture report, you have to start the antibiotic according to the blood culture and sensitivity report. You can, once you are treating empirically, you can give ampicillin, gentamicin, you can give cefotaxime, you can give ceftazidime, you can use vancomycin with amikacin. Before the patient gets infection, prevention is one of the important tools by which we can prevent the different causes of the sepsis, like group B streptococcus prophylaxis. Group A streptococcus infection is the most common cause of early onset sepsis. This early onset sepsis secondary to the group B streptococcus has been reduced by 80% by use of the intrapartum antibiotic prophylaxis that should be given to the mother, because 10 to 30% of the women, their genital tract is colonized with the group B streptococcus. And mothers should be screened with 35 to 37 weeks of gestation for their involvement of the group B streptococcus colonization of their genital tract. Nosocomial sepsis in an ICU can be prevented by the hand hygiene. That is the single most important strategy for avoiding the transmission of infection. And minimize the handling, promote the breastfeeding, a little bit told about the probiotics, and equipment and supply should not be shared between the infants. They will minimize the invasive procedures. And visitors should be minimized. Nursing should be clean and dust-free. There should be daily surface cleaning with water and detergent. Blood spill should be removed immediately with any disinfectants. Walls, windows, doors, curtains should be cleaned regularly. Progresses, I told you, it depends upon the clinical status of the baby. If there is severe involvement, then the chances of mortality are high. And if the patient is arrived with the SIRS, then the prognosis is good. Overall, its mortality is after early onset sepsis is 5 to 10%, and late is 2 to 6%. Thank you very much, students, for your listening. And today we discussed about the sepsis. Inshallah, in our next lecture, we will complete the neonatology and we will start the other topics. Thank you so much. So I will unmute, and if you have any question, you can ask. So students, any questions? Hello? Any questions? Excuse me? Students can do it. Students can do it. Thank you very much. Inshallah, we will discuss about the NEC in our next lecture. College come inside. Front of the people.